and some example of technetium radiopharmaceutical concept. This is first generator in 1958. No shield, nothing. So basically, technetium generation consists of a chromatographic column containing ammonia emitted by cyanide. Molybdate bound to ammonia, high negative charge, and aluminum is positive. So chloride ions will use technetium. So basic principle, as you see, aluminum is strongly positive column, and high negatively charged molybdate species with high acidic pH, which bind to ammonia. And that makes the pre-technetate loose in the column. So this is basically generator is the big cow. This is how in Europe they call it, and just saline and milk it and give you illusion. So the most important in technetium generator is very complex system, and that's with high radiation, which give high energy, which will actually create radioactive species, react with the with water molecules, H2O, and this will give you species like hydroxide, hydrogen, electron, and etc. So hydrated electron and free radicals may react with moly and technetium, creating new unwanted chemical species. So the time to elute, this is we need to concentrate on this and elaborate, because we found that most of the people they don't know about this. Technetium generator comes usually. We always just throw first elution. Why is that? So this is how to calculate, but for maximum activity 22 hours. So what I wanted to say is about technetium 99. So the mass of total technetium will depend on, of course, moly, time between successive elution yield. The ratio between technetium and technetium 99 will depend on interval between time between elution decay. For example, the amount of total technetium in 10 gigabecquerel 24-hour interval is generated approximately 0.2 microgram. In 96 hours, interval between elution amount is about 1 microgram. That's a lot. So in other words, is the longer technetium not eluted, the higher percent of technetium 99 is formed. And you know, technetium 99 is exactly the same as technetium 99M, chemistry-wise. So what you label with technetium 99M will be labeled with technetium 99. And that leads to lower specific activity. So the time between elution, for example, 6 hours is the highest percent between the ratio between technetium 99M and technetium 99, which is 1.5 to 1. But as you see, 72 hours is the ratio is 1 to 12. So if you receive the generator and, for example, in Saudi Arabia, the weekend, we receive the generator, it says 5 days, then weekend, which is about 7 days, then first day, which is Saturday, when it comes to elute, is 72 hours. If there was no on-call case, wouldn't be eluted. So in this case, the amount of technetium 99 is higher than technetium 99M. For example, this is the bone scan after 72 hours. I see the resolution. You can look to the spine. A lot of technetium 99 is taken over, which is we don't see. And this is 18 hours, higher resolution. And you can see more actually this is in the cardiac system. Maybe this is 72 hours. You probably see in the projection the myocardial muscle. But in 6 hours elution, because you have more technetium 99 in lead. So continuous why choosing technetium, which is available, short half-life, pure gamma, and the criteria of PET's technetium. It contains reducing agent, filling materials, So radiopharmaceutical preparation simple is pre-technitate plus reducing agent plus ligand give you the complex or the molecule you're looking to. So the reaction is performed by using a kit vial containing sterile original ingredients able to yield a product within a short time. That's the criteria in medicine for a kit. Usually the chemical reaction that requires no more than 1-2 steps, that's the kit is we're looking for. The reaction should be carried out in physiological solution. Strictly controlled sterile biology-free condition. All ingredients should be pharmaceutical quality and used in amount below their toxicity. So when you receive a new, for example, if you change the vendor from one company to another, and let's say MDB, and you never heard about this. These are the things you have to look at and read about it. Always there is people ahead and they doing research on that because the amount of molecules is different. So if you're using to the labeling amount of activity, it might change with that one. So the quality is very important, the quality control. Mainly it's actually radiochemical purity, which is the fraction of the stated radionuclide present in the stated chemical form. So the most common use is HPLC. HPLC is a preferred method for well-chemically characterized compound. The solvent in TLC, please read the instruction with the manufacturer which solvent to use. Sometimes you need to use MEC, sometimes acetone, sometimes homosalate. So it's not always the same. Even if it's the same compound, sometimes when it's different company, sometimes the solvent is changed. So this is the mostly used diphosphonate complex, MDB or HDB. This is very convenient, very stable molecule. DMC is very stable also, very stable. You can do 24 hours delay with no problem. HMBO is one of the weak compound molecules that can be used. So always use fresh evolution, use with 30 minutes. For example, in brain death, do the QC twice with 2 person and pulse injection. MIBG is very good compound for renal scintigraphy, but it is a weak compound. But always the study is done within 30 minutes, 1 hour. Why I'm saying this? Because in a few hours, MIBG is break down in the biological system. So doing delay after 4 hours, you might see bowel. And if there is ectopic kidney or partial kidney, this could be obscured by this unwanted activity. So always use the patient must be hydrated. Half dose to solitary kidney. As you know, that the development and revolution in nuclear medicine equipment now is advanced, and if you remember in the old days, the sensitivity is low, and we're giving that high dose to. I think it's the time for us to study the dose we're giving to the patient. Before the sensitivity of the camera is not like nowadays. So I think we need to work on this more and evaluate. And we have done some few cases there with half doses, which is worked very good. Technetium IAEA is one of the routinely used in practice, which is 90% particles between 10 to 90 microsize. Nothing should be more than 150 micrometer and longest. Usually the particles between 100,000 to 500,000 particles. So even though these appears to be very large numbers, there is a very large margin of safety. Why? Because there are billions of capillaries with there. So we only blocked about 1/1000 capillaries. So in lung shunt hypertension and pregnant pediatrics mainly, no more than 60,000 should be used. So when the physician requests half dose, it's half dose of particles. It's not half dose of activity. And most of people, when you tell them just half dose, they do just the dose in activity-wise. but actually it's particle-wise. The problem that when the kit made just a fish, that's fine, the concentration is okay. But usually MAA from 6 to 8 hours expiratory. So if we half dose at time of preparation is different than half dose, and activity-wise, because the volume sometimes double or triple. So if you do that, you might give actually more than triple the particles needed to be injected to the patient. Let's say that your dose is, for example, 185 megabecquerel. If you get half dose, that give you half particles when you prepare the kit, but when it's decay and the volume was 0.5 now, and after 2 hours, 3 hours, the volume is 1 point something. So if you give half dose, will be about 1 ml, and this number of particles will be doubled. And sometimes you see kidney in perfusion, especially with pediatrics. If you don't see thyroid and you don't see brain or something, that is not chance. Because there is 10% allowed with the MA, 3 technician, but when you give a lot of particles, that will lead to the possibility to showing the 3 technician in the kidneys. So GA reflux, this is very high. We gave half dose. You can use nanocolloid or sulfocoloid. Sulfocoloid is preferable for aspiration. As you see with the new equipment, the sensitivity is very high. Actually, sometimes it's better. You don't see the steroid effect. So blood cell medication might interfere with labeling with the RBC. So MIBG is a combination of benzyl group, beryllium and ruthenium. It was developed in early 80s, and it structurally resembles norepinephrine. It's interneuron-defined cells by active uptake mechanism. The mechanism of uptake usually it's in radiopharmacy, active uptake or ion exchange or replacement, and is stored in neurosecretory granule. MIBG scintigraphy used in image tumors for neuroendocrine tumors, particularly those with the sympathoadrenal system, like neuroblastoma, which is common in children. So iodine-123 is the choice because it's pure gamma. But iodine-131 is widely used due to cost and availability, especially those who they don't have access on iodine-123. So minimum activity of MIBG iodine-123 is 80 megabecquerel, and maximum is 400, while iodine-131 35 megabecquerel, and the maximum activity is 80 megabecquerel. Although with this low activity, still the dose given by iodine-131 is much higher. If you see the bladder by iodine-131 is 1.7, while it's 0.084 to an iodine-123. So you see, MIBG is the choice for neuroblastoma, especially the avid MIBG to the cell of neuroblastoma is very effective. Even it can show early response. So I'm saying this because sometimes there are some medication where too many drugs might interfere with the uptake with MIBG. So in a injection, of course, check the possibility of interfering drugs, just in case if you see unusual uptake, then you would know what was the reason. If there was biopsy or chemotherapy, saturated with potassium iodide, and there are a few patients sometimes they are allergic to iodine, so we use them instead of potassium perchlorate 3 times a day. While with iodine-131 you have to increase this because longer half-life. So injection and post-injection, MIBG administered in slow, that's very important, with slow intravenous injection, at least 5 minutes, and preferable not to use central line. And if you use a central line is used, is giving it even more slow. So usually the adverse effect, tachycardia or vomiting, abdominal pain, but usually doesn't combine with the slow injection. So rapid injection is contraindicated, which is might give this adverse effect. Patients should be encouraged to drink a lot of water and vitamin D. So parameters high having impact on stability. We always will need high specific activity, but high specific activity actually sometimes might give you degradation in the compound. So especially with MIBG I-131, then when you receive MIBG I-131 with high activity, always keep it in the fridge and freeze it actually. Because there is aqueous media, there is radiation, which is leads to hydrolysis and radiolysis. So physiological distribution, these are about the radiopharmaceutical house distributed and the percentage distribution in the body, colloids and HSA. In conclusion, learning more about various criteria of radiopharmaceuticals might help in more safer production and radiopharmaceutical preparation, and more safer human application, and design and developing new products. Recent development in information imaging has impact on scan time and radiation dose reduction. Thank you very much.